Good afternoon, everyone, and welcome to today's St Vincent's Foundation webinar. My name's Lynn Amy, and I'm the CEO of the St Vincent's Foundation. I'd firstly like to acknowledge the traditional custodians of the land on which we meet today, the Aboriginal and Torres Strait Islander people. I pay my respects to elders past, present and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Victoria. St Vincent's has a very proud history of community support, which dates back to 1889, when the Five Sisters of Charity arrived in Melbourne with the dream of opening a hospital. And I just want to say that ever since then, and all through the years and right up to the time we're in today, you in the community have been so important to us and in enabling us to continue to improve the service that we provide to patients and to families here at the hospital. And our goal here at the Foundation is to raise awareness about the different health issues that we are tackling today, to raise awareness about the research that we undertake, about the clinical improvements that are happening across the hospital, and to raise funds to support the brilliant care that we provide here through our wonderful work of our clinicians and our nursing staff and our researchers. So we want you to know, those of you in the audience today who are supporters of the hospital, how very much we appreciate absolutely everything that you do, and we don't take a single thing for granted. I did want to take this opportunity to mention our Gift in Will program, because that program is so important to us and has been for a very, very, very long time. And I would really encourage any one of you who hasn't already done so to think about potentially leaving a gift in your will to support the work of the hospital. It's a really wonderful way to leave your own legacy. And of course, anyone who enjoys, I'm sure all of you will find the presentation today really fascinating, then I would urge you to go to our website and consider making a gift. I wanted to say as well, Robert Nash is convening our question and answer session today, and Robert will also be closing the session at the end. He's a senior member of our team. I wanted to say thank you to everyone who submitted a question so far. And if anyone else has got a question that you'd like to ask, please submit that at any time during the session via the Q&A box, which you'll see at the bottom of your screen. Sorry, I've got a bit of a tickle in my throat. It's not COVID. So now it brings me to the time of introducing our very much loved presenter of ours and a very highly respected physician here at the hospital, Associate Professor Yvonne Bonomo. Yvonne is a graduate of the University of Melbourne and a physician in addiction and adolescent medicine. She not only leads a multidisciplinary team here at St Vincent's Hospital, but she also heads up a number of key research projects. Some of you would have already heard about some of her amazing research. Her research focuses on exploring approaches to address the prescription opioid problem and various other mental health and substance use disorders and novel treatments for addiction in the community. Yvonne is very much about nurturing future leaders here. She teaches medical students, junior trainees, physicians and psychiatry registrars, and she has many advisory roles. So I'd like to take this opportunity to welcome Yvonne. I know the subject of addiction is something that impacts all of us to a greater or lesser degree, either us or members of our family or people that we know in our networks. And we are very keen to hear what Yvonne can share with us today. Thank you, Yvonne.
Great. Well, thank you everyone for the opportunity to speak today. I feel quite humbled to be here talking about a topic that is so close to my heart. So over the next half hour or so, let's talk about the nature of addiction. Did anyone watch the series recently on the ABC called Sanditon? It was Jane Austen's story, and I know that some of you in the audience watched the series. In one of the episodes, there was a very interesting line about love. So let me play it for you. Lady Susan gives a very interesting perspective on her definition of love.
I should ever fall in love, it would not be with a man like him.
My dear girl, you cannot determine who you fall in love with. It is an affliction, like the measles.
So love is an affliction like the measles. That had me thinking. I'll leave it to you to consider whether you think love is an affliction, but it made me think that addiction is an affliction. Not like the measles in that you don't have it one day, but you do have it the next, but perhaps more like love in the sense that early in the addiction, it welcomes the person, it cradles the person, it brings them comfort, it makes them feel, warm until it doesn't, until it takes control of their lives. So if I were to be Lady Susan talking about addiction, I'd be saying, my dear, addiction, you don't choose to have an addiction, it is an affliction, and together we can manage it. So with that in mind, let's talk about what addiction is and what it isn't, what leads to addiction and do genes matter, and what are we doing here at the Department of Addiction Medicine at St Vincent's in Melbourne. There are lots of things in our community that are potentially addictive. So I've just put pictures of a few of them here: chocolates, sweets, coffee, social media, gambling, online shopping. And many of you will be saying, oh yes, I'm addicted to that, or I'm addicted to another picture there. What I can tell you is the good news is that more than likely you're not addicted to those activities. In fact, it's a habit. It's a way you console yourself when you experience a certain trigger, be it stress or other, but it's not actually addiction. Which brings me to talking about what is addiction and what isn't. And if we focus on substances and drug use in particular, drug use is not the same as drug addiction. So drug use is a voluntary, preventable behaviour. Okay, you can choose to drink alcohol or you can choose not to. You can choose to smoke or you can choose not to. You have that control. And it's very, very common in Australia. The National Drug Strategy Household Survey is run every 3 years and gives us a snapshot of what's happening in the community. And for the last two surveys, we have seen that 43% of Australians report having used a substance illicitly. Now that might be alcohol or tobacco, it might be an illicit drug, or it might be a pharmaceutical drug that they have used not as prescribed. So it's this growing, moving feast of substance use that we are seeing in our community. Drug addiction is not just a lot of drug use. It's actually compulsive drug seeking, even when you know that it's going to cause you negative health and social consequences. And we also know that it's a chronic relapsing disease. This article by Nora Volkov, who heads up a team in the United States that really has driven a lot of the research that we now understand around addiction. This article summarises the key neurobiological processes that occur when someone has an addiction, and it really helps to understand what's going on so that we understand when people relapse why that's occurring. And she basically describes 3 different pathways are occurring. So of course, everyone knows about the reward pathway, and you can see on that slide the reward pathway that's deep inside the brain. And most people know that the drive to use substances is for that reward, that release of dopamine that makes us feel good. In fact, people with addiction with time will tell you that they don't feel that reward anymore, that the release of the neurochemicals is so minimal that they only use to keep themselves going, not to feel that euphoria that they felt early on in their addiction. But the second process that's happening in the brain is that when someone is not taking substances for a period of time, so they're abstinent, they get a profound what's called dysphoria. And that means that other parts of the brain are working to make that person feel completely lacking in energy, low in motivation, depressed, not having any sense of meaning in their lives, and a feel of real discontent. And I have patients come and tell me, Dr. Yvonne, I've been off the alcohol now for 3 months, or I've been off the methamphetamine for a month, and is this all there is what they'll say to me. And that's that dysphoric, those pathways that make one feel dysphoria. And then the third neurobiological pathway we know is occurring is that the prefrontal cortex of the brain, which is the part of the brain that helps us decide between a good decision and a bad decision, or discern the consequences of something, doing something, that is not working appropriately in addiction. So it's impaired in its function. So 3 very important processes that are all co-occurring at the same time. And why that's important to understand is because when Joe Blow goes to a detox or withdrawal unit and then moves on to a rehab and stays in rehab for a while and then comes out and within a month has relapsed to their substance use, we might feel frustrated, but we must remember that there are those very powerful processes that are occurring within the brain, and that it is very difficult to maintain that abstinence for prolonged periods of time because those powerful circuits are firing. Now, it doesn't mean that the person's a robot and they've been hijacked by their brain and they can't overcome these processes, but it takes a lot of work and a lot of time to be able to counteract or override those 3 processes, which is why it's important that we as a community understand that it's not a lack of motivation or a immoral decision. It's brain circuits that are firing, that are very strong, and that lead to the natural history that we see with people with addictions. So what leads to addiction, and do genes matter? Well, it might surprise you, but we actually have to go back to the first 1,000 days of life. The first 1,000 days is from the point of conception to the end of the 2nd year of life. And that is an incredibly important period of human development, because what we know is that during that time, experiences, exposure, the environment are all impacting on the growing baby and then the young child, and actually embedding biological changes that will lead to the trajectory of that person's health right through to their adulthood. So what happens in that stage can actually inform or influence whether someone has cardiovascular disease, has a stroke, develops obesity, develops mental health problems, or has an addiction. So it already starts way back then. And why does it start then? Because we know that genes can either be switched on or off. Neurobiological pathways are being set. It's like the baby and then the developing child are predicting the kind of environment and life they're going to have, and their physiological systems are adjusting accordingly. So that's very important start to the trajectory that we see in the people that come to us for help. Then we get to adolescence, and as you will well know, adolescents are wired for reward. They will pick up cues that will provide reward far sooner than any of us do in our older age. And most of you will know that the adolescent brain takes a while to develop. It develops, it's a work in progress as the young person gets older. And it's a peak time for experimentation. And at the same time as that experimentation is happening, we know that there is 2 processes occurring within the brain: pruning and myelination. And what I mean by that is it's really like a use it or lose it phenomenon. So those brain circuits that are exposed and are being used will be consolidated and they're myelinated. So basically those nerve cells are being made to transmit signals more efficiently. And those circuits that are not being used are pruned. So there's removal of certain neurons. So I often describe to parents that the adolescent brain is like a ball of wool that's got knots in it. And as the young person grows, those knots are being taken out or are being undone and straightened. The other important part of adolescent brain development is you'll see on the slide the little square that compares the 5-year-old to the preteen, to the teen and the 20-year-old brain. And as I mentioned before, that prefrontal cortex, that part of the brain, the front part of the brain that helps one discern between what's a good decision and a bad decision, that helps one discern the potential consequences of doing something. You will see in those pictures there that it only turns blue being mature, that the nerve or the brain circuits there are mature now. It only becomes mature when they're in their 20s. So the longer we can delay exposure to substance use or other addictive behaviours or activities, the longer we can delay it, the better off the young person will be in terms of the long-term consequences. So if we can delay it beyond 20, then there's less likely to be that pruning and myelination of the circuits that we'd really rather not have consolidated, like addiction circuits. And then we get to adulthood, and that's when we see them. So as you can imagine, when adults present to us for help, there's been all this trajectory leading up to their presentation to see us to get assistance with their addiction. So you can imagine it's not an easy thing to do or to change rapidly. Nonetheless, we are up for the challenge and things can be done. But the research shows that on average, the average time from the onset of the addiction, so not substance use, but the addiction, the average time from the onset to seeking treatment is 20 years. So we'd like to see that gap narrowed and people come sooner, because then we can get more effective treatments and outcomes. So that's the nature of addiction and what leads to addiction. What are we doing here at the Department of Addiction Medicine at St. Vincent's here in Melbourne? Well, our vision, if we could wave a wand and make the world perfect again, our vision would be to have universal access to the best practice treatments for the addictive behaviours. And by universal access, what we mean is that if you turn up to your GP, or if you mention to your nursing friend, or if you come to the hospital, wherever you present and you mention that you want help with your addiction, that you could get that help straight away, that people would know where to ring, know where to go for help, and there wouldn't be barriers to accessing the treatment as we currently see. We also, in our grand vision, would like to see, you can see in the light blue circle, a great patient and carer experience. Because while the patient is carrying a lot of burden with their addiction, we're equally aware that the carers, the people around them, the loved ones or the family, other family and friends or support services are finding it difficult to manage someone who is going through the highs and lows of an addiction. So we would like to see more help for carers in relation to looking after people with addictions. Multidisciplinary approach, you can see in the bottom right-hand corner, is a given in addiction treatment, and I'll talk about that a bit more in a moment. But most people with addictions need a range of disciplines, so we would love all disciplines in health to be aware of the addictions and to understand how to manage them or where to refer them. We want to, and we are working on capacity building, because we know that people in rural and regional areas find it even more difficult than in metropolitan areas to access help. We would like to see everyone advocating for our people, because it's through talking about the issue of addiction and how it comes about that we can help people understand that it's not a weakness of someone, or it's not a crime, it is a health condition and it needs to be managed like any other health condition. And of course, we do research and translation, and we'd like to continue to build on that research and raise the questions that come up in clinical practice that sometimes when you go to the research literature, you can't find the answers to. And I'll briefly talk a little bit about that. So I'll talk briefly about the treatment that we do, what we do for education and research, and start with treatment. Now that photo there is a very precious photo to me because that is the first page of the logbook, and I have held the logbook in my hand, this very logbook, which is the logbook of the first clinic for alcohol problems in Australia, here at St Vincent's in Melbourne. And you'll see, or you may not be able to see, I'll have to read it for you, but on page 1, that first column says special clinic, because that's what it was called, the special clinic. I love that name. Patient number 1, and we've blotted out the name. He was male, he was 43 years old, and the date he was at his first outpatient appointment here at St Vincent's in Melbourne was the 29th of June, 1964. And the second patient was 38, female, so came to the clinic the same day, and the red writing says that she died, doesn't say when. And then the third patient was a 50-year-old male who came on the 6th of July and also died. Look at the legacy that St Vincent's has started, and we feel so humbled to be continuing that tradition and the foresight of the giants that preceded us, who started up the first treatment in Australia for alcohol problems. And here we are today, still working away at it. It's a great honour and very exciting to hold those logbooks, which are currently now with the archives. But when it comes to treatment, there are 3 pillars, and you have to address all 3. If you miss out one, you're wasting your time. And the first one is the social context. The second one is behavioural strategies and psychology, and the third one is medications. And I'll very briefly talk about those. You might be surprised that I mentioned social context first, and that's because if someone's homeless or if someone's lonely, and we know that there are a lot of Australians who are very lonely, even pre-COVID, they were reporting loneliness, or if there is violence in your home setting, then trying to deal with the addiction and reduce the substance use is never going to work until you address these things first. So that's where the multidisciplinary approach comes in. We need the multidisciplinary team to assist to address the addictions from all angles. And while I'm talking about the individual that's sitting before us, there is the broader social context. If we step back, there's the broader social context that we need to consider. And one of those is the stigma of addiction. The World Health Organization have reported that addiction is the most stigmatized health condition of all the health conditions, above mental health conditions. We need to address that, and that's why I wanted to explain what's going on in addiction, so that we don't stigmatize the people who run into problems with alcohol, drugs, or other addictive behaviours. We need to understand what's going on and remove that stigma so that the access to treatment happens more readily. And then the policies and the protocols that our state government and our federal government come up with sometimes fly in the face of being able to treat people with addictions. So there is that broader context that I did want to mention, that it impacts our ability to treat patients that come to us for help. But the second pillar of treatment in addiction is the behavioural strategies. And I've listed just a few there. So motivational interviewing, cognitive behavioural therapy, family therapy, AA, NA, others. There are a lot of different behavioural strategies or psychological approaches, and all of them have a place in the treatment of addiction. So sometimes people will come to us and they will say that they need to go to AA. That's the only thing that works for me, Dr. Yvonne, and I need to go, and that's fine. Other people will come and say, I don't want to bar AA. I've tried, it doesn't work. What else can I try? Some people have, when they present to us, they are so befuddled with what's happening in their lives, they don't know what they want. And that's when we can advise what we think from our point of view is the right treatment or the right strategy at that particular point in time. But it is important to know that it can change over the trajectory of the addiction treatment. What that person needs from a psychological point of view may change, and that's perfectly okay. I have put in red there, it needs to be appropriate for adolescent development, because if an adolescent is coming for treatment or for management of substance use, and we tend not to see them here at St Vincent's, we see 18-year-olds and older, but it does have to be appropriate to their stage of development. So the way you might speak to an adult in terms of psychological strategies is quite different to the way you'd speak to a 17-year-old about strategies to address the triggers to their addiction or the management of their substance use. And then there's the medications that we use. And I won't go into the details of those, but suffice to say that we have medications that are helpful in alcohol problems. We have them for opioid problems. We don't have much in the way for cannabis dependence, but we are looking at medicinal cannabis as potential treatment, and I'll talk about that shortly. And for methamphetamine or ice, there aren't any specific treatments, medication-related treatments yet. It's more the other two pillars of treatment. So you can see that for different addictions, there are different, the three pillars still apply, but which pillar is more preferential to the other varies according to the context and the person. But an important key message to take from today is that once you have an addiction, you'll always have it. You have that vulnerability, it's been expressed, you will never be cured, as in it'll never go away. What we aim to do with addiction treatment is manage the addiction, hence the quote of Lady Susan earlier on. That loony cartoon on the slide there with the peaks and the troughs is how addiction treatment goes, basically. So we try to stabilise people. We get them to the point of stabilisation. We get them feeling like they are back in control of their substance use. They have a sense of their identity. They have some meaning in their lives, and they feel empowered to live life. And then life will hit them, throw them a curveball, and things might, as I say, make them wobble. And the ideal outcomes of treatment is that the person will ring up if they haven't been attending treatment, if they've been travelling quite well and not needing any support. They will be able to recognise when they're lapsing or relapsing. So they're two terms we use in our field. Lapsing is a return to substance use that isn't quite back to where it was, but it's starting to trend that way. Relapse is when you're right back to square one. Either way, what the ideal position is that person would pick up the phone, ring up and say, I need to come back in, I'm struggling a bit. And they do, and they come back in and we get them back on the straight and narrow, and then they travel forwards again without needing supports, and on it goes. That is optimal treatment in addiction. That is what we should be expecting. The community tend to expect that people will be abstinent for the rest of their lives. That is not the case. Now, I'm sure some of you are thinking of people who've attended AA or who continue to attend AA and don't relapse. And you're absolutely right. But they themselves would say they are not cured, they are in recovery, and they're managing their addiction through attending AA and remaining in recovery. So I hope that makes the concept of addiction and its treatment clearer for everyone. In terms of education, we do the traditional model of education as everywhere else in the hospital. So that's the apprenticeship model. But we also have or are exploring novel models of training. So we're partnering with different organisations within our sector, excuse me, to help work with other workers. So where drug and alcohol agencies don't have much medical support, we provide that support either through telehealth or telesupport and help them manage the people that they're seeing. But we also are quite proud of the ECHO model that we've been running, which we've been running for the last 3 years. And ECHO stands for Extending Community Healthcare Outcomes. And that's an evidence-based model, internationally renowned. Started in America, in the state of New Mexico, which is quite similar to Australia in that that state has very vast distances between towns and the main city. And so it's difficult for people to access treatment. And so the way the model works is through a hub and spoke model. So that top photo there is our St Vincent's group, our hub, and that's a pre-COVID photo. So we haven't sat that close to each other for a very long time now, and we're in a different room and we sit much further apart. But when I looked at that photo, I sort of started, because it's been such a long time seeing us all sitting so closely together. But you can see that the team is looking at, and the other photo there where we've blurred out the people who are beaming in online from all over Victoria. And the model runs for an hour every Wednesday morning. So we were there early this morning. And the format is to have a 10-minute presentation to update people's knowledge. So it might be, today we're going to revise the pharmacology of methadone. And then we have 2 case presentations, de-identified. But those people, those spokes there, will present a case that they are seeing, and they will describe the treatment that they've provided, and they might ask a question to the community of practice. So it's not just to us as the addiction specialist team, but to the whole community of practice, where there's ideas shared, and sometimes people know of resources in their local area that others don't know about. So it's a great way of bringing the tyranny of distance, or addressing the tyranny of distance and getting capacity building happening. And this is just a heat map to show how far the reach of our project ECHO is. And those dots continue to grow. The size of the dots shows how many people are in those areas. But you can see that we are spanning, using technology, we are spanning quite a broad part of the state. And it's, you know, highly, for us, it's highly stimulating to be hearing and learning ourselves about what the difficulties are in the rural and regions, and being able to provide some support. And likewise, I think our community of practice enjoy asking us difficult questions. In terms of research, I could talk for 3 hours about research, but I won't. I will just briefly give you an overview of the areas of research that we're looking at. So our research that we do is driven by the desire to drive better clinical outcomes. And they fall into 4 domains. So we do some basic science where we partner with organisations like the Florey Institute. And just to pick out one of those research projects, we're looking at genetic vulnerability to methamphetamine abuse. So there's a particular gene that has been identified in animal models that if the adolescent is exposed to, has that gene and is exposed to methamphetamine, they are more likely to run into methamphetamine problems down the track when they're older. It's been shown in the animal model. We're now looking at it in humans because that gene also occurs in human beings. So that's one of the projects we're doing in terms of basic science. We also, as Lynn mentioned, are keen to look at prevention, because as you heard before, that trajectory of addiction starts very early. So if we can start to prevent problems right from, you know, the get-go, then we're in a better position all around. So our Prescription Opioid Practice Improvement Project, or POPI, pardon the pun, was a 3-year project generously funded by the Inclusive Health Fund at the hospital. And we looked at how young doctors prescribe prescription opioids to patients when they're leaving hospital, and how can we improve the way they prescribe it so that that problem then doesn't become more prevalent in the community, because a lot of the opioid problems we're seeing in the community start from poor prescribing practices. And if we don't expose people to opioids unnecessarily, then we're not going to get that broad problem of opioid use disorder. We look at a number of treatments, and really the treatments we look at fall into 2 categories. So one category is repurposing of drugs. So certain medications such as vigabatrin and lorcaserin are medications that were already on the market that were being used for indications other than addiction, and because of the way they work, we were using them as treatments in addiction. The other group are the newer therapies. So you can see listed there medicinal cannabis, which we're going to look at in terms of can it help people with cannabis dependence. And you'll see there the mention of the psilocybin and MDMA, so the psychedelics that I'm sure you're reading about in the media that are garnering interest. And so we're exploring what the evidence is around that in terms of can they help people with addictions. But in amongst all of that treatment, you might see music therapy. So we're not solely focused on medications, remembering those 3 pillars I mentioned. Music therapy has been shown to be of benefit in helping people's mental health, in helping them cope with their anxiety. And so we have done a pilot trial to show that people, when they're going through withdrawal, if they're engaged in music therapy a session a week, they actually learn to regulate their emotions and find it quite calming. So we're now extending that study to look at that in more detail. And finally, policy. We do some research that helps to inform policy, and probably our biggest project in that regard was the drug ranking study, where we brought together from across Australia 22 experts from different fields, not just from the health field, but police and the court system and so forth, and ranked drugs according to which were the most harmful in our Australian context and which were the least harmful. And in case you're dying to know which were the top 2 drugs or substances, I should say, it was alcohol and methamphetamine that caused the most problems in our community, which, using the same methodology used, applying the same methodology in other countries, such as the UK, the results were quite different. For them, it was alcohol and fentanyls or opioids that were more problematic. So you can see that between different cultures, there's different problems that arise with the various substances. So in summary, as Lady Susan said, she was talking about love, but I will talk about addiction, and I will say it is an affliction. You don't choose to have it or not have it. But the important thing is to remember that together we can manage it and get good outcomes. And with that, I'll finish and open up to any questions.
Thanks, Yvonne. Yes, there's certainly been a lot of questions submitted when people registered, so I'll go through them first, and then there's also quite a few that people have written live through the Q&A box, so we'll work through them after that. So thank you so much, and yeah, if you do have a question, pop it in now, because we've got so many we might go a little bit over. But the first one I'll go with is from Sawani, and she's asking, is there a link between eating disorders such as anorexia and alcohol addiction?
Yes, there is, and with other substances as well. And in some cases, the eating disorder predates the substance use, and in others, it's the other way around. So many mental health disorders are associated with substance use disorders. It's like they're, it could be that they're genetically linked. We don't know that yet, but we do see in clinical practice, we do see that they can coexist. And sometimes the substance use is the way that the person, it's the way that they can avoid eating by taking substances. So yes, there is an association, the nature of which is still to be clarified.
Great. And Jacqueline's asking, are there gender-specific addiction trends?
By and large, what we see in the treatment context is that our patient population are 2/3 male, 1/3 female. But having said that, that doesn't mean necessarily that women aren't running into problems with addiction. It's more a reflection of the difficulty in accessing treatment because they've got other commitments and because of the stigma. And so we think that's probably more the reason why women don't feature more frequently or with greater prevalence in our patient population. Having said that, what we are observing is that when women start to develop an addiction, there's a phenomenon called telescoping where that trajectory of addiction progresses very rapidly, so much faster than it does in males. Now, why that should be so, we don't know. It may be, as I said, that they're just not accessing the treatment early enough, and so things go much faster before anyone can bring in any help. Hard to know, but yeah, the balance tends to be more male than female at the moment, but that's not to say that women in the community aren't suffering with addictions, and we need to break down those barriers so that they can access help as well.
Great. Robert's sort of stating that the average Australian spends 7 times more on gambling than the average Canadian. Problem gambling is not amenable to medical treatment. The state derives 13% of its income from gambling. Does this make it the worst addiction that we're facing?
Yeah, well, thank you for pointing that out. Gambling is a big problem for us all. We would consider gambling addiction as part of our bread and butter. We don't get a lot of referrals for gambling, and you mentioned that there's not medications available. There are a few that have been tried and do work in some people, but by and large, if we go back to the 3 pillars, it's more the psychological strategies or the behavioural strategies that are the most important or that are used first. Having said that, you make a very good point that in Australia, we have this gambling issue that we aren't really looking at closely enough. So if you look at the global data, the United States and China have the most number of gamblers. But if you look at gambling losses in terms of American dollars per head of population, Australia actually leads the leaderboard, and then Singapore comes second. So when we're doing all this betting advertising, gambling advertising that we see on the television, and you can bet your bottom dollar young people are seeing it through their social media. And remember, I was describing that adolescent brain. We are developing a perfect storm for longer term problems with gambling. So in that sense, it is a real concern that we aren't doing more about gambling as a society. So taking that step back and thinking in terms of the social context. And I read a statistic recently that said an 8-year-old Australian will not have seen, if they watch football, will not have seen an AFL match without being exposed to gambling advertising. Now think about that and the brain development that I spoke of earlier. If that doesn't make us worry, I don't know what will, but it is an issue and it does need to be addressed because we will be feeling that pain down the track with long-term consequences.
Okay, and Robin's saying there's a common belief that harm reduction is a better strategy than total abstinence. What are your thoughts on which is better and why?
I don't think you can say one's better than the other. it's all about where the person's at in their addiction trajectory. So while we might want to aim for abstinence, and while we might hope that the person we're treating also wants abstinence, if they talk to us and say, Dr. Yvonne, there is just no way I am going to stop drinking, don't want to do it, can't do it, whatever, don't even want you to think about me being abstinent, I'll still work with that person and I will bring in harm reduction strategies and hope that with time, as the trajectory, as the person moves along that trajectory, they might come to the conclusion, and they often do, that actually they do need to be abstinent. But in the meantime, harm reduction measures need to be put in place so that they experience the least harm possible. So it's been very common, and one of the first questions I'll ask patients when I'm speaking with them about what their goals are, I say, you know, how do you feel about being abstinent from alcohol or whatever drug it is for, let's say, 6 months? And they'll either say yes, definitely, or they'll say no way, can't even think about it. And I'll say, what about 3 months? No, can't think about that either. 1 month? No. Well, at least I know what page we're starting on, and then we'll work together. And down the track, very often those people will say to me, you know what, I think I need to be abstinent because I can't do this controlled drinking or controlled substance use. So it's not a matter of whether one's better than the other. It's more about what will keep the person as safe as possible while we walk this journey and get people to where they ideally want to be but can't quite see themselves being there yet. I hope that answers your question.
Great. And James is asking, where or how does the line of responsibility for addiction treatment / prevention separate or blur between the user and the provider?
So that sounds to me like you're asking or saying, what happens when you can bring the horse to water, but you can't make it drink? And that happens a lot. And what we do in those situations is, if we're not able to see the person themselves or they won't come in, we will work with the organisations or services with which they're involved, if they've got services involved with them. So it's kind of like secondary consultation, and we'll make suggestions or we'll discuss with them how best that person can be helped. It might be that harm reduction strategies need to be brought in to help keep that person safe, again, like in my previous response, while we're trying to get them to a place where they can accept treatment. The other thing is that we always leave the door open. So in terms of making it clear to the person, so if we're not seeing them directly, then telling the services that are working with them that we will always see them, that when they're ready, we're there, there'll be no judgment, come in, we're happy to work with you, we're waiting for you. And in fact, I remember one young woman that we were waiting to see for a long time, who would never turn up to her appointments. And when she finally did, I said to her how fantastic it was to see her, and we'd been waiting to see her for a long time, and it was so great to see her, and she burst into tears. So it made me realise that sometimes what you see and what is not exactly what you might think you're seeing, in the sense that the person might not look like they want help, but actually deep down inside they do. They just aren't able to show it yet. Notwithstanding that, some people, aren't necessarily wanting treatment, and that's when, as I said, we work with the services that are involved with them, or with the carers if there are no services. And then the third point to make is that if that person is at really high risk, so if the substance use is such that their life is at risk, there is a specific act, the Severe Substance Dependence Treatment Act, where you can mandate treatment for 2 weeks. And that is run through St. Vincent's here with us at the Department of Addiction Medicine. That's for a very at-risk group where people are concerned for that person's life. So it won't be for everybody, but there are different levers that one can manoeuvre to try to assist that person with the addiction and hope that eventually they'll come to the realization that we don't have two heads and one eye, and that we don't bite, and that actually maybe together we can work out a better way of living and feeling.
That sounds really good. So Ian's asking probably a bit of a tricky question. How do you measure the success of treating addiction?
That is a fantastic question. So most people, so the community, as I mentioned before, measure the success of treatment as being abstinence. A lot of research to date has looked at abstinence as an outcome measure, as the primary outcome measure. But from practice, we would say there's a lot that happens before abstinence that is really good and is a good treatment outcome. So for us, it's not necessarily abstinence. It may be that the substance use is reduced to a point where it's not causing problems for the person or those around them. They are able to function. They are able to control that substance use or keep it limited to certain contexts. And that for us would be a good treatment outcome. That their mental health and well-being is better, and we measure that in our population to see whether, despite the substance use not being completely gone, they're actually feeling better about themselves and they're actually functioning better. They are good clinical outcomes or treatment outcomes. So you can see it's a much broader definition of good clinical outcomes than either the community or the research to date has focused on. I think the focus on abstinence is a bit too narrow because abstinence comes a lot later. And as I said, there are many preliminary good outcomes that you can observe or that the person will report to you that are on the way to getting, the best outcome possible.
Good. All right. And Jackie is asking, what can we do to support children / break the cycle of parents who have a diagnosed addiction? And she's got a specific case of sex addiction, gambling, personality disorder, particularly between a father and son.
Yeah. So as you heard, the development, that trajectory, so the exposure, the environment, and the experiences that young person is in is putting that young person at very high risk of following a similar path. So what can be done is intervention, be that with supports. It's hard to answer that question in detail in a forum such as this, but the important factors are to change the social context, make sure that child is safe, try to encourage, if the adult isn't already in treatment, try to encourage them to enter treatment. One does have to think about whether child protection needs to be involved. I don't know about the details, but they're the kinds of things that we would be considering in terms of knowing that this young person is at very high risk because of the context they're living in, and then putting in as many protective factors as we possibly can. And those protective factors will be other adults that can provide support and care and keep that young person safe, other activities that get that young person away from potentially dangerous or addictive activities, and really helping that young person to develop resilience through helping them as they grow through their adolescence, learning how to problem solve, how to manage tricky situations, how to regulate their emotions. So you can see there's lots that can be done. The fact that it's been identified that this young person is in a high risk situation is the first step. And then a whole lot more needs to be done to keep that young person safe.
And one of the Q&A questions is, how do you support someone whose network is also affected by addiction? Is there a way to provide support when their support network are also in the same position?
Yeah, very difficult. We see this all the time. So not easily done, but possible. So things like we run here a relapse prevention group, and during COVID we did the relapse prevention group online. So that starts to move the person away from a network where there's drug use and drug dealing towards a group that's like-minded in terms of the outcomes that they're seeking, which is to feel more stable and find more meaning in their lives. But also there are welfare services that can be brought in and or they can be connected with them so that they can start to create new networks that aren't engaging in the substance use. As long as that person's in that network, and very often they're enmeshed in that network, so it makes it very difficult. But just because it's difficult doesn't mean that we don't try everything possible to help them see other potential networks that they can engage in. But being, I say to patients, as long as you're hanging around those people that are doing something that you're trying not to do, it's like going on a diet in a cake shop. It's really going to be challenging you. We're already trying to work on those 3 neurobiological processes that are really, really embedded and take hard work to overcome. Don't make it harder for yourself by being in those networks. So yeah, there are groups and there are places that people can go to start to slowly move away from unhelpful networks to more constructive supports and networks. But I do acknowledge that it's not easy to just drop one group and then find yourself in another one.
No, it sounds a difficult situation. So last question, it is 2 o'clock, so we better quickly answer this one. I thought this would be interesting. Are obsessions the same as addictions? Sometimes when I start something, even a hobby, I feel like I get obsessed and then it feels like I'm addicted.
Yes, so that goes back to my point about when we do things. So the short answer is no, obsession's not the same as addiction. They're probably different brain circuits, but they can co-occur. So yes, I won't diagnose you over the forum because I'd need to know a lot more, but they're similar, but not quite the same. Not the same in the way they present and not the same in terms of the underlying neurobiological processes. So yeah, that would be my short answer to that one.
Well, thank you so much, Yvonne, for your time and for answering all the questions, and certainly apologies to the many questions I'm sorry we didn't quite get to, which is a pity, but yeah, we certainly appreciate your fascinating presentation today. So a big thank you to you. And for those that are watching, we have recorded this session, and we'll, if you want to share it with your friends or family who weren't able to attend, or we'll send you a link to that hopefully by tomorrow. Before we wrap up, I'd like to let you know that we have decided to hold our next webinar in September, so we're having a month off. So please keep an eye out for our announcement. We'll send you probably an invitation to the next one. And if you enjoyed the webinar, we'd be extremely grateful if you could consider making a donation to support the vital work of St Vincent's. Just head to our St Vincent's Foundation website, which is stvfoundation.org.au. So thanks again for everyone for joining us. Thanks again, Yvonne. We hope to see you next time, and have a lovely day.
Thank you. Have a lovely day. Bye.